Good evening, everyone. Thank you for tuning in for this Zoom program presented by the East Brunswick Public Library's Just for the Health of It Health Literacy Initiative and co-hosted by St. Peter's University Hospital. Tonight, we welcome back Dr. Dinesh K. Singal to give his lecture, Hypertension, the Silent Killer, focusing on better understanding high blood pressure, the signs and symptoms, and how to treat high blood pressure with both lifestyle changes and medications. Dr. Singal is the director of Cardiac Catheterization Lab at St. Peter's University Hospital and founder of the Cardio Metabolic Institute. He is a board-certified cardiologist with decades of experience serving patients. If you have any questions, please put them in the chat and we will try to get to them at the end of the lecture. I appreciate all of you being here, and now I will hand the floor over to Dr. Singal.
Well, thank you, Marissa. Thank you so much for this opportunity. This is one of the most common problems I face in the office when I see patients. And what I'm going to do today is give a small and brief background on what high blood pressure is, how it impacts us, what are some of the negative connotations of not adequately treating it, and then how to treat it. And to begin with, we'll just start with understanding what is blood pressure. So blood pressure is basically the force with which the heart is pumping forward and the resistance which is offered by the blood vessels. So this is a picture of the heart. This is a big tube called the aorta, and blood is squeezed out from this heart into the aorta and to all the blood vessels. And there is a certain force which is needed by the main chamber of the heart to pump this blood out. If there is resistance to this force, then the heart has to work harder. So just think of a table and you have a bunch of books lying on it, and you put a lot more books, a lot more weight. You have to apply a greater force in order for you to push that table. So similarly, the heart then has to work harder, and that pressure which is generated goes up. So high blood pressure, which is also known as hypertension, is when your blood pressure, the force of your blood pushing against the walls of your blood vessels, is consistently too high. So before we get into specifics about blood pressure, let's just understand the degree of problem we face with in terms of the spectrum of this condition on a global level. So if you look at all the reasons why people die, and you separate out communicable diseases, which are infections, and then you just look at the non-communicable diseases, there's about 39.5 million people who died back when WHO looked at this data, and of which, from a heart standpoint, cardiovascular standpoint, that was about 17.7 million people because of either strokes or cardiac heart disease. Now, we all know that blood pressure goes up as we get a little older. However, this is not just a problem of the elderly. When they looked at non-communicable diseases in 2015, 15 million people died between the ages of 30 and 69. And this shows you how many people are dying because of cardiovascular disease relative to infections and injuries. High blood pressure kills nearly as many people worldwide each year as all infectious diseases combined. So if you populate all the various kinds of infections right here, this is the number of people who die because of high blood pressure. And this graph shows the percentage by which deaths from cardiovascular disease could be reduced if specific risk factors were brought under control. So if you quit smoking, these are the number of people whose lives would be saved. If we took care of sodium, air pollution, high cholesterol, these are the number of people whose lives would be saved. But see what happens when we control blood pressure. these are the number of people whose lives can be saved. So these are preventable deaths which take place on an annual basis. So let's get into a little bit of the physiology of high blood pressure. So again, this is the heart. This is the big tube called the aorta, and it has a few layers in it in the wall. And typically when we are young, this wall is elastic. So when the pressure is pushed from the blood is pushed from the lower chamber of the heart into the aorta, the tube is elastic. So it's able to accommodate, so the pressure doesn't go up as much. But as we get older, some of these layers will get thicker. So there is a muscular layer, and this will get thicker, especially if the pressure is running a little high. So in response to that, the wall gets thicker, and as the wall gets thicker, the pressure also goes up. And as the pressure is going up, it causes a little bit of damage to these inner lining of these of this artery, and that inner lining damage then results in building up a plaque. As blood is flowing through, it has cholesterol in it, it meets this damaged lining, and plaque starts building up, and that causes obstruction of the artery. So one of the reasons why people get heart attacks or clogged arteries is high blood pressure. There are many other reasons also, but uncontrolled or inadequately controlled blood pressure contributes to the building up of this plaque and eventually leading to a heart attack. And then when a heart attack takes place, or if the heart has been working very hard in generating all this pressure over a period of time, the main chamber of the heart, and this is the inside of the heart, starts getting bigger and bigger and eventually gets tired. And once it gets tired, is not able to push enough blood through, it causes what's called congestive heart failure. So one of the most common causes of congestive heart failure is hypertension. So now, not only has the blood pressure caused a heart attack, it is also causing what we call congestive heart failure. So here are some of the problems which occur with hypertension. It's not only the heart. Because of the increased pressure in the brain, blood vessels can break open and cause a stroke. It can impact our eyes and we can lose vision. We talked about heart attack. We talked about heart failure. It also can impact the kidneys. In fact, one of the most common reasons of kidney failure, as well as people on dialysis, is again, the damage which is caused to the kidneys because of high blood pressure. And it also leads to sexual dysfunction. So because the blood is flowing through all our blood vessels in the body, the impact of that high blood pressure is felt by all the different organs of the body. Okay, so what is blood pressure in terms of numbers? So here we have what we call a normal blood pressure, which is 120/80. So the blood pressure has two numbers. One is the systolic, the upper number, and then there is a diastolic. So systolic kind of represents the squeeze of the heart, and the diastolic kind of represents that aortic pressure, which is in that elastic tube I showed you. So these are the two pressures. Normal blood pressure is 120/80. Anything above that is increase. So if it's between 120 and 129 on the upper end on the systolic number, and diastolic is still less than 80, we call it elevated. Once it exceeds 130, we start calling it hypertension. And there are various stages. Stage 1 is when the blood pressure is running between 130 to 139 on the systolic side, and the diastolic is running between 80 and 89. That's stage 1 hypertension. If it goes above 140 and on the systolic side and 90 on the diastolic side, it's called stage 2 hypertension. And if it's over 180 over 120, it's a hypertensive crisis. This is a fairly serious condition, and we'll talk about what it can do. So, this question comes up often. How should we be using a blood pressure monitor? And how and when should we be measuring our blood pressure? So the first thing is to remember that if we are active, if we are walking, if we are going up the stairs, our blood pressure is going to go up. That's normal physiology. So in order to get a more objective and correct measurement, we need to be still. So we need to be still. We need to sit preferably in a chair, not on a sofa, not on a recliner. You preferably, as much as possible, sit in a chair, and you should try and measure the blood pressure typically about the same time every day. Now, the blood pressure during the day will fluctuate. Blood pressure is never a static number. 100% of patients during the day, if they take multiple readings, the pressures are going to be somewhat different. So in order to have a fair comparison, it helps if we're taking it on the same time every day. When you start taking a reading, take multiple readings. So take maybe 2 or 3 readings with a gap of a few minutes each and record the results. And avoid taking the measurements over clothes. So sit in a chair, wait a few minutes, keep your arm kind of straight. The blood pressure cuff should be on the arm and a little bit above the elbow, so that it's not so you can get a reliable measurement. So here is a big challenge where our work is cut out. If you look at the data, this graph kind of shows you that only about 14% of people have their blood pressure actually controlled. If you look, 37% of people are getting treatment. And 47% are aware that they have blood pressure, and 100%. So if you take 100 people, about half of them are aware that they have high blood pressure, and about a third are getting treatment. But guess what? Only a small fraction are being controlled. Now, this is a chronic problem we have. When I get patients in the office, we bring up the discussion of high blood pressure. A lot of people, say, I don't want to take a medication. Or if I take a medicine, I will not be able to stop it. Or, let me watch it for some time. So that what happens is there is long periods when the control is not adequate. And here is an important statistic. A reduction of 20 millimeters of blood pressure can have mortality by almost half. So between at the ages of 35 to 69. So a reasonably small drop in blood pressure can significantly reduce our risk of mortality, risk of dying. So it's really important we understand that it's a team effort for us to control the blood pressure. It's the patient, it's the physician, and we all have to not only recognize that we have blood pressure, which is this group, but then we have to accept and do the right things, as we will talk about, to get this under control. Now, there are some elements in our daily life which increase the blood pressure on top of what we have. A common problem is decongestants. So some of the decongestants do have elements which will raise our blood pressure. One of the main culprits for high blood pressure is salt intake. So cutting back on salt is really huge, and we'll talk a little bit more about it. Alcohol, weight gain, and prolonged sitting. So this inactivity, gain in weight, alcohol intake, and salt, these all lead to a higher blood pressure. So what can you do to do a better job in controlling your blood pressure? So the first and foremost, if you saw, half the people don't even know that they have high blood pressure. So knowing your numbers is extremely important. So whether it's a physician's office, whether you get a blood pressure instrument at home, knowing those numbers become important. Obviously, you need help of your healthcare professionals. So it's a good measure to have your annual physical. And if there is a problem picked up, then you obviously have to see your professional more often. And then you have to make a few lifestyle changes. I'm going to talk a little bit about in the next slide. And I would strongly recommend, if you have high blood pressure, it's very important to get a blood pressure instrument and at home and check it. These are not very expensive. In 50 to 75 bucks, you can get a reasonably decent instrument at home and check your blood pressure on a more regular basis. And then if you've been prescribed your medication, take your medicine. And a strong recommendation is not to fight your physician if they are trying to give you a medication. It's true that not all medications will agree with the patient, but sometimes there has to be some back and forth in order to find the right regimen which will work. In terms of these lifestyle changes, what are things we can do? So again, healthy weight. Weight is such a huge element. Today in my office, I saw about 3 patients who had lost about 20-25 pounds, and their medicines had to be cut back. It plays a huge role. Eating healthier. So a lot of fruits and veggies, low-fat dairy, and less saturated and total fat. So all of this, again, plays into the weight. It plays into healthy intake of nutrients, and that helps to control the blood pressure. And once again, salt plays a huge role. The average American diet, it is estimated, has about 10 to 12 grams of sodium, when we actually need somewhere about 2 grams of sodium. So 1,500 to 2 grams of sodium. If you go to IHOP and you have one of their big breakfasts and you look at the sodium content, that might be the content for the entire day. Every food item we take has a little bit of sodium. Most food items have some sodium in it. So all of that adds up. So the less salt you can take, the better off you will be in terms of your blood pressure. The other thing is to get active. The recommendations are at least 90 minutes to 150 minutes of aerobic or dynamic exercise per week. And that, if you divide by on a weekly basis, so if you can exercise about a half hour, 3 to 5 times a week, that will get you the kind of time which you require for regular exercise. And then again, cutting back on alcohol, not more than 1 or 2 drinks per day, or less if possible. And then there are medications. We have a lot of medicines out there, and here I just highlighted some of them. So I tell patients, when we're looking at medications, and this only comes in after we have taken the blood pressure a few times. We don't just rely on one reading, because again, it can vary different times of the day and at different instances. And when patients come to our office, there is this entity called white coat syndrome. Sometimes the anxiety and stress makes the blood pressure go up. So we're not relying on one blood pressure reading, but if on multiple readings, 3 or 4 different readings, we are getting a higher blood pressure, and we have tried whatever we could from a lifestyle change. We've tried to lose some weight, we've cut back on salt, we're doing our exercise. Blood pressure is still high, we have no choice. We may require some medicines. And when it comes to medicines, I kind of tell patients it's a stepwise approach. It's like going up the ladder. So on step 1, there are kind of 4 groups of medicines. So here are the 4 groups of medicines, and I put down a couple of common examples of what you may recognize if you're taking one of these medicines. So the first class is a diuretic. So these are what we call, in layman's terms, water pills. The 2 common ones are hydrochlorothiazide and chlorthalidone. Now, diuretics, the amount we give is generally not, in most cases, not enough to cause a lot of urination. So some patients sometimes will hesitate to take them because of that reason, but these are very low doses. They're really trying to get rid of some salt and sodium and therefore bring down the blood pressure. Every medicine has a positive and some downside. So I'm going to mention the little bit of downside for each one of them. So both of them can sometimes lower potassium. So we do have to measure potassium in the blood and make sure that that isn't going down. Again, the doses are small, so it really shouldn't impact the kidney function in a big way. Beta blockers, so common ones are metoprolol, atenolol, there's a bunch of others. They not only lower blood pressure, they will also lower heart rate. So sometimes as we're getting older, the heart rate may be coming down, and therefore we have to cut back and watch for that. Otherwise, they're generally reasonably well tolerated. Some patients can have fatigue, but generally they are reasonably well tolerated. Another group of medicines is called calcium channel blockers. A common one of that is amlodipine. The brand name is Norvasc, and there's another one called nifedipine. They are very, very commonly used. They're fairly effective. One of the downside with the calcium channel blockers is they can cause some swelling or edema on the lower extremities. So, and most of it is dose dependent. So if somebody is having edema or swelling, we can cut back on the dose, and that sometimes will help. On occasion, we are not able to give it at all, but otherwise they're a very, very commonly used group of medicines. Another group of medicines it's called ACE inhibitors. So ACE inhibitors and angiotensin receptor blockers, these are sister medicines. And so we don't use both, but we use one or the other. So ACE inhibitor, common example is lisinopril or ramipril. This group of medicines, one of the side effects of this medicine in about 10% of people is that it can cause a cough. We also have to check potassium levels and kidney function levels. So when I start somebody, I usually will check within a 2, 3, 4 week period, a blood test to make sure everything's okay. And then the other one is an angiotensin receptor blocker, which if there is cough with this group, we can try this, and that will help. So the other thing to remember is there are patients who will use one medicine and do very well. Some need 2, some need 3, some need 4. So I have patients who are on all 4 groups. And because the medicines are being used so frequently in multiple people at 2 or 3 different groups, it's not uncommon that pharmaceutical companies to make combination medicine. So that's very common to find a medicine which is a combination of amlodipine, olmesartan, and hydrochlorothiazide all in one pill. So in order to improve compliance, these groups will, these medicines will be put together in one pill. So this is common. Now there are other medicines also. I didn't go through all of them. There are medicines like clonidine, doxazocin, hydralazine. So there's a bunch of other medicines, but this is usually what you will find as the first line, which is used by most physicians. Now, there are instances when the reason, hypertension has been called a silent killer is because in most instances, a person will have no symptoms. So if your blood pressure is 150/80, 9 out of 10 people wouldn't even know that their blood pressure is high. There's an occasional person who runs a little lower blood pressure and they will feel it, but most people won't. And that's why over time, hypertension has been called the silent killer. So it's really important to get the number taken, because without checking the blood pressure, you would not know whether the pressure is high or not. On occasion, the blood pressure will really go up and it can reach a crisis level. And the readings can be as much as 180/120. And here is a list of things which it can cause. And I alluded to that earlier. So stroke can cause loss of consciousness and memory loss, right? So if there is change in sensorium and the blood pressure is high, that becomes kind of an emergency. Heart attack, it can lead to damage to the eyes and kidneys, loss of kidney function, aortic dissection, angina. So this is a long list, but basically, if the pressure is this high, it can lead to stroke, it can lead to a heart attack, and it can lead to what's called aortic dissection. So it's really important to get attention and go to the hospital, call 911, and there usually the emergency room doctors will be able to give some intravenous medications which can help control the blood pressure. I'm going to go through certain myths which are out there. And, you may or may not relate to this, but it's not uncommon for me to have patients in the office who have concerns and are kind of resistant to getting some treatment because of the myths, which I'm going to go over. So one myth is, well, high blood pressure runs in my family. There's nothing I can do to prevent it. So, it's okay. My father lived or whatever, and it was this high pressure. So this is not true. It doesn't matter if your family had high blood pressure. It's true that if your family member had high blood pressure, you may have high blood pressure. Part of it may be that the whole family is eating more salt than usual, but some of it is genetic. Some of it could be weight related, because sometimes that runs in families too. But it is just because a family member had it doesn't make it right for you, and therefore you need to control it. Another myth is Another myth is that I don't use table salt, so I'm in control of my sodium intake and my blood pressure. Well, guess what? You go to a Chinese restaurant and have a soup there, or you buy canned food. Or the other day you went and had pizza. That cheese has a lot of sodium in it. You had some ham, that has a lot of sodium in it. So there are a lot of food substances. And if you go to a grocery store and start looking at the labels, you will notice that almost every food item you're picking up has an element of sodium in it. So the source of sodium is not just table salt. It is in a lot of the foods we eat. So being cognizant of that, controlling that can go a long way in controlling that blood pressure. Another myth is, well, I use kosher or sea salt when I cook instead of regular table salt. They are low sodium alternatives. Well, that's not true. Chemically, kosher salt and sea salt are the same as table salt. It has about 40% sodium and count the same towards total sodium consumption. So that is again a myth. There's another myth. I feel fine. I don't have to worry about high blood pressure. So once again, you go back to one of the slides I showed. There's 100 million people. If you take 100% of people, half of them either don't know that they have high blood pressure because they feel well, or even if they know it, only a fraction of them are well controlled. So high blood pressure, again, is a silent killer. It will that blood pressure will kind of eat our organs. And remember, if we drop our blood pressure by 20 millimeters of mercury, we can halve the risk of cardiovascular death. So it really goes a long way. This is an extremely preventable problem, at least in terms of our premature dying, by controlling the blood pressure and not relying just on the symptoms. So here's another myth. I read that wine is good for the heart, which means I can drink as much as I want. That is not true. The wine has calories, it adds to weight, whatever form of alcohol. So in moderation, there may be some merit, but unlimited alcohol is not correct. Another myth, I have high blood pressure and my healthcare professional checks it for me. This means I don't need to check it at home. Well, you may see your healthcare professional 2 or 3 times a year. And those numbers, middle of the day, you're walking from the car, those are not sometimes the true reflection of what's going on rest of the time. In fact, there is a huge initiative, and I give Medicare credit for it. Unfortunately, most of the Medicare Advantage plans who really are trying more to make money rather than invest in the well-being of the people they are responsible for don't cover it. But Medicare has this initiative called remote patient monitoring now. They recognize the importance of good control of blood pressure. So for example, we run it in our office, and we're in a position to give our patients a blood pressure instrument. The neat thing is not the instrument, but the fact that once they take the reading, it comes to us. And I have a full team which monitors these blood pressures, and we are able to intervene and act and make sure the person's doing all the right things, whether it's medicines, whether it's lifestyle change, on an ongoing basis. We're not waiting for those 2 or 3 or 4 visits in a year to make adjustments. We're engaged on an ongoing basis. So that program is called remote patient monitoring, and it's really a big help in doing a better job in controlling people's blood pressure. So the reading in the office alone is not enough. It's always good if you have high blood pressure to get an instrument and check it on a regular basis by in a technique which I mentioned earlier. Another myth, I was diagnosed with high blood pressure, but I have been maintaining lower readings, so I can stop taking my medicine. So this is a big question, whether it's cholesterol, whether it's blood pressure. I get, well, now things are good, I'm going to stop taking my medicines. Well, that's not right, because unless you've dropped 20 pounds and have you really cut back on salt, in most cases, the medicines are only going to keep controlling the problem for the period of time you're taking it. So once you stop it, the readings will go back to where they were. So stopping it is not the right thing. Monitoring the blood pressure, yes. I mean, if the pressure goes down, you can back off and work with your doctor to do that. But in most instances, just stopping it is not the right thing, because, and especially certain medicine, there's a drug called clonidine. If you stop it abruptly, the blood pressure can even shoot up even higher. Most of the other medicines is less of an issue. but it's never wise to just stop just because the pressure is good. Because the pressure is good because you're taking the medicine and following some of those instructions. So we went through what is blood pressure. We went through what are the organs it can harm. We talked a little bit about lifestyle change. We talked a little bit about medicines, and we understood why some people are resistant to doing the right thing because they have certain beliefs which are not true. Well, why should we focus on high blood pressure treatment? Well, guess what? It is affordable. So losing a little bit of weight, exercising, that doesn't cost anything. The nice thing is we're at a time when almost all the medicines I just went through, they're all generic. You can get 3 months of these medicines for $10 or less. So it's an affordable treatment, and we can really make a big dent on the risk of cardiovascular death if we do that. And it is simple. The unfortunate problem, again, is that despite it being simple and it being essential, we still have our work cut out to do a better job in controlling the blood pressure. And here is a statement here. Treatment of hypertension in primary care can save more lives than any other primary care treatment program. So, in a nutshell, what I would say to all of you is that this is a very common problem. Blood pressure causes a lot of impact on our bodies. Blood pressure is the dividends we get by controlling it are significant. There are some lifestyle changes which can go a long way, especially the salt intake reduction and weight loss. And there are plenty of medicines. And if we engage both as patients and as well as professionals, we can help reduce the burden of stroke. We can help reduce the burden of heart attacks and kidney failure. And heart failure. We spend billions of dollars. And here we have a simple treatment, which is not fancy, which is not very expensive, but we have to recognize it, accept the problem, and be engaged. So that is my message for the day, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Singal. Okay, if anyone has any questions, can you please put them in the chat? We have so far just one. And the question is when to get a carotid ultrasound.
So typically, so first of all, carotid ultrasound is an ultrasound of the arteries in the neck. And the major indications are, if somebody had some symptoms which could occur if the carotid artery was clogged. And what are the symptoms? Dizziness, lightheadedness, any symptom which mimics a mini stroke. Obviously, somebody has a stroke. Or when you go to a physician, and if they listen to your carotid arteries, they put a stethoscope on the artery in the neck, and they hear a sound. We call it a bruit. It's a sounds something like a whoosh, whoosh. So I routinely listen to the carotid arteries, and if I hear the sound, then I would get a carotid ultrasound. Sometimes people going for some vascular procedures like open heart surgery will get it as a routine. But just routine in somebody who's otherwise feeling well, at least there is no guideline to do that. But if somebody is symptomatic, yes. So that's the most common reason why we would get a carotid ultrasound.
Thank you for the answer. I don't see any other questions so far. We'll just give them a moment, see if anybody else wants to ask a question.
So while let me just share a few few things while people have a chance to ask any questions. So we run some programs in our office where We focus, our dietitians actually do some cooking classes to show how you can cook very nutritious, very healthy food without adding salt. And when folks go through that program and start following some of those guidelines over the last few years, in almost majority of the instances, I have to cut back on the blood pressure medicines. We've seen firsthand how cutting back on salt makes a huge difference. And I mentioned earlier, I had 3 patients today who had lost, especially with some of these new medications now, like Ozempic and Mounjaro, people are losing weight. We're having to, and even other than that, if somebody just watching the diet, cutting out junk food, eating smaller portions, they wind up coming in and we have to cut back on the medicines. So it's very common for us to be able to cut down medications if a person really makes those meaningful choices in their daily lives. So I can't stress enough the importance of a healthy lifestyle in both preventing hypertension to begin with, but also making it less likely to need a lot of medicine to help. One other condition I didn't mention earlier, which I find is a big problem, is sleep apnea. There's a lot of people out there who have sleep apnea. And if somebody has sleep apnea and is not treated, in those instances also, controlling blood pressure is difficult. So getting that treated is also very helpful. And one other example I'll give you is if somebody is having pain, back pain, knee pain, some kind of discomfort, then the blood pressure will go up also. And the treatment there is to deal with the, whatever we can do to deal with the pain, because that's what's leading to the blood pressure going up, and it's not the other way around. So we obviously have to help the blood pressure, but more importantly, we have to help the discomfort.
Thank you for that extra information. We have a few more questions coming in. So next question is, how often to see a cardiologist after age 45, even with regular normal numbers?
Well, there is no need, a guideline to see a cardiologist. We're busier than ever. I think the first thing you should do is have a good family practice doctor or an internist. So if you have your PCP who checks you out, does your physical, checks your blood pressure, and does your routine labs, then they're able to deal with most of what is needed. Where we get patients is either the primary care physician isn't comfortable with handling whatever situation there is. There are instances where I'll get people who have a family member, brother, sister, parents who at a young age had a heart attack. They would have some concern to come in and see us, and may make sense to at least a one-time visit where we can do some additional screening. If cholesterols are extremely high, that would also be a reason to see someone. But just because one is 45 or 50 or 55, that by itself may not be a reason. The only caveat I might make is if there are risk factors for heart disease. So what are the traditional risk factors? Diabetes, smoking, strong family history, hypertension, high cholesterol. So if somebody has a bunch of those and or is symptomatic, having some discomfort in the chest or difficulty breathing when one exerts, those are reasons. But otherwise, if you're running around and we are very physically active, eating healthy, no symptoms, blood pressure is fine, lipids are fine, we're not going to add value to the care which a primary care provider can provide.
Okay. Next question is, can we reduce the dosage of medicine if the BP is under control?
Well, again, depends on, if let's take a couple of examples. If with 2 medicines, the blood pressure is 120/75 or 120/80, I would not lower the medicine. On the other hand, a person comes, they've lost 10 pounds, they've cut back on salt, and now the pressure is 105/70. Yes, I could, there were two medicines. I may not stop, but I may start weaning off and cut back a little bit. So, the reason the blood pressure is normal with medicines is because the medicines are on board, because it probably was high when they were started. So if you cut back on the medicines, then the pressure is going to go up and we defeat the whole purpose. So I would not recommend coming off the medicine if the pressure is normal. On the other hand, if the pressure is lower because of whatever lifestyle changes have been made, then yes. Can someone come off the medicines or back off on medicines? Yes, but it requires lifestyle changes. It requires cutting back on the salt. It requires regular exercise, cutting back on dropping weight. So if you are able to do that, treating sleep apnea. So if you're able to do that, yes, but not just because the pressure is normal, because otherwise it will go up.
Okay, and let's see here. Another question asks, does stress hurt the heart?
Yes, absolutely. So let's understand, what does stress do? So stress leads to us producing a lot of adrenaline, and adrenaline causes the blood pressure to go up. It also causes heart rate to go up. All that creates shear forces which work on the blood vessels of the body, and that then causes damage to the lining and causes more plaque buildup. So stress is a major factor which is underrepresented, under-recognized as a factor which leads to heart disease. And again, the mechanisms are multiple. There have been studies, I'm a very strong proponent of lifestyle change to help reduce plaque buildup. I believe, there is evidence which has shown that you can reverse plaque. But in order to do that, not only do you need exercise, you need good nutrition, but you also need a healthy mindset. What does a healthy mindset means? It means the ability to deal with stress, the ability to stay calm under difficult situations if you can. I mean, we all go through different phases, but as much as you can. So if you're feeling stressed, look into some meditation. Yoga, meditation, and whether it means talking to a counselor, but meditation plays a huge role in being able to deal with stress. But stress is extremely important. It leads to overeating. It leads to again, we're talking about blood pressure, so raised blood pressure. So huge role. There have been studies where they've looked at the incidence of heart attacks in periods when a whole demographic or whole community was under some kind of stress. They've looked at people who used to commute to New York, let's say cities, or like a good example would be New York, crossing the bridge and the stress of traffic and whether they didn't go. So those populations seem to have high stress. Times of economic uncertainty raises stress, and people have looked at and done research and found higher incidence of heart attacks in those periods. So stress plays a huge role.
And another question, the way I'm seeing it here is, would the amount of water intake be something of concern or something that affects blood pressure?
So there's no direct correlation of blood pressure with fluid intake. In general, drinking a lot of fluids is good. The only caveat is somebody who has congestive heart failure. Those people have to be careful both with salt and fluids. So I'm going to leave that population out. But other than that, drinking, a large part of our body is water. And, we have both sensible and insensible losses. And staying well hydrated is extremely important. It also helps in, if you're drinking good amount of fluid, it helps to a degree curb our appetite because the stomach gets stretched, and that helps in portion control. But in general, we need a good amount of hydration. And if one is thirsty, that makes the body uncomfortable. The blood pressure with any kind of discomfort will go up. But there's no direct correlation as such with, you can't just drink a lot of water and expect your blood pressure to go down. But in general, it is healthy and good to drink a lot of water because our body needs it. Our body is, a large portion of it is liquid, is water.
Okay. I have someone asking, they said that they take metoprolol,
Yeah.
and they want to know if you could tell them a little bit more about I can't pronounce it well. It's ezetimibe, Ezetiimibe.
Okay, so metoprolol, so they're talking about metoprolol and ezetimibe, right?
Yes,
Okay.
that's the one.
Okay, so I was trying to see if I could bring up that slide. Give me bear with it. So metoprolol is, oh, there it is. Okay, so metoprolol is a beta blocker. So beta blocker, so the heart has receptors on its surface, and these receptors are called beta receptors. That is how, so every part of our body has receptors, and that's how it's an address for the chemicals to know where to go. So the beta blockers go and block these receptors so that the heart rate goes down and the blood pressure goes down. So if I get a patient who has palpitations, I would put them on a beta blocker, and that would kind of be a barrier between the heart on one side and the outside chemicals, the adrenaline floating around from outside. And that slows the heart rate, it lowers the blood pressure. It comes in various strengths. It starts, the lowest dose is 25 milligrams, can go up all the way to 200 milligrams. It also comes in two different forms. There is a short acting, which is metoprolol tartrate, which is a twice-a-day drug, and metoprolol succinate, which is long acting, which you can generally give once a day. So most of our medicines do more than one thing. So we use metoprolol for blood pressure. We use it for people whose heart rates are fast, or atrial fibrillation, or some sort of tachycardia. We also use metoprolol in people who have weak hearts. They have congestive heart failure. It helps those people. So there are many uses of metoprolol, very widely used medication. The downside is it will lower the heart rate. So somebody whose heart rate is low, then it becomes a little bit of an issue. So that's metoprolol. Ezetimibe is a medicine we use for lowering cholesterol. The brand name is Zetia, and it's a non-statin. Typically, if somebody needs something to lower cholesterol, we first go to a statin. And if the statin is unable to control or bring the numbers down to an adequate level, we would add ezetimibe or Zetia on top of that. So today, I think I must have written 3 or 4 prescriptions of ezetimibe today on top of a statin. Occasionally, there'll be somebody who's intolerant to statins, and we would add ezetimibe. The way it works is it prevents the absorption of cholesterol from within the intestine. So our body has a system where cholesterol we ingest, body makes some, it goes back into the gut and then gets reabsorbed. So this kind of helps in preventing absorption of cholesterol right in the gut. So it's a non-statin. Statins work in the liver by reducing production. So it generally is well tolerated. It only comes in one dose, which is 10 milligrams. Generally doesn't affect the liver, and will lower cholesterol by about 20% or so. So good medicine, not usually first line, but is a great add-on to existing statin therapy.
Okay. Someone is asking about the carotid ultrasound. What's the limit? When is surgery needed?
Got it. So when we do a carotid ultrasound, what we are looking at the artery is the speed with which blood is flowing through the artery. So the principle is that if an artery is restricted, the blood has to flow faster through that narrow area. So that's called the velocity. We then take that velocity and translate into a certain percentage of blockage, and there's a range. So a velocity of a certain number can be translated into a degree of blockage less than 15%, 16 to 49%, 50 to 79. In most cases, if a person has no symptoms, we consider surgery if the blockage is estimated to be more than 80%. So 80% or greater is the cutoff when we start considering surgery. The exception is if somebody was having neurological symptoms or they had a mini stroke or a stroke and they were even more than 50%, we may consider. But in general, in someone who's not having symptoms, the cutoff is 80%.
Okay. Let's see, what time is it? We have one question that says, when is the lowest BP reading in a day? Is that morning, noon, or evening?
Well, that's a tough one. Everybody is a little bit different. In most instances, it probably makes sense to just take a reading in the morning, but everybody is kind of different in terms of we have a lot of people whose blood pressures we are measuring, every day, and we find that it varies. But generally, the right time to take it would be sometime in the morning hours. That's just the appropriate time. But and partly because the stresses of the day are going to make the blood pressure go up. Every external factor is going to play a role. It also depends a little bit on somebody's on medicines and what medicines they're taking. So the blood pressure does fluctuate all day long. We get patients in the office middle of the day and their pressures are lower. But in general, it's a good idea to take it in the morning. But I don't think there is any specific time I can tell you when it's going to be the lowest.
And I think this will be the last question for the night. Someone says that they work out, they're vegetarian, and they watch their salt, but they want to know if their coronary score is good, and if they feel great, do they need to take the 12.5 hydro that their doctor recommends? Their pressure is elevated, and beyond, it is in the hypertension level 1.
Well, the answer is yes. I mean, it doesn't matter, because what you're trying to avoid, just because, remember, the title of this talk was that hypertension is a silent killer. And, so maybe look at it this way. Any prevention is better than a cure. We know what hypertension does. And if your pressure is high, then there is some other component. Maybe it's a genetic component which is causing the pressure to be high if you're doing all the right things. So the bottom line is, if the blood pressure is high, it's not going to be helpful in the long run. So you're lucky that there is no if your coronary calcium score is a little bit different area, but still is related, because hypertension can cause plaque. So you're lucky, things look good, and you want to keep it that way. And we know that high blood pressure leads to problems down the road. So all the more reason that we have recognition of this problem, and we have a treatment available despite you doing all the right things. So the answer is, if in the physician's judgment, the pressure is high and they're recommending a medicine, the answer is yes, you should be on it. You should take it.
Okay, well, that's it for the chat questions for today. And again, I thank you, Dr. Singal, for doing this lecture and answering the questions from the audience today. It was very informative, and I hope everyone walks away with a better sense of high blood pressure and how to take care of themselves for their well-being and for their health.
Well, thank you. Thank you for this opportunity.